Great, thank you. So the genetics clinic and what it is and what to expect is sort of the plan for this talk. So Tammy and I are both registered genetic counsellors. We both work in the Sheffield service for the EDS diagnostic clinic. So this is Tammy, who is not here today, and me. Tammy's been a genetic counsellor for about 10 years, been with the EDS service for the last 3 years, and brings a lot of experience with her. She is wonderful. If anybody's met her, hopefully you think so too. And I've been a genetic counsellor just a little teeny bit longer than Tammy, but I've been with the service since it was first set up in 2009. So we're looking at about 12 years now. So between us, we have a good experience in genetic counselling and in the rare types of EDS. So the first thing that people often say when they meet us is, what is a genetic counsellor? It's not a term that most people have come across unless they have been seen in a genetics clinic. I thought I'd give you this definition. So this is from a recent publication. So we are trained to help individuals and families understand, and sorry, I can't see all of my screen because I've got your lovely faces in the way. So I'm just going to that's slightly smaller, thank you. Understand and adapt to the medical, psychosocial and family implications of how genetics contribute to diseases. It's a lovely definition, but what does it actually mean? So what is the role of a genetic counsellor? We provide information about genetic conditions. So we work very closely with consultant colleagues. Genetic counsellors are not medically trained to make diagnoses, but we do provide a lot of information about conditions when a diagnosis is known. We talk about how genetic conditions are inherited. Often families have their own ideas of how a condition seems to be passed on. And sometimes this is absolutely spot on, but sometimes it's not quite right. So sometimes you might hear things like, well, in our family, it's the second eldest child, but only if they're born on a Tuesday, and they're definitely going to get it. So there's a few bits that we kind of talk to families about when we're sort of working out what do they believe so far, what is their understanding of the condition, and then we try and sort of talk about the science and make sure people have a good understanding of how genetic conditions are inherited. In doing that, we can talk about who else in the family may be affected. So genetic conditions are slightly different to a lot of medical conditions in that when you make a genetic diagnosis, it can be a diagnosis for that person, but there can also be implications for other people in the family, and they may be current family members or future family members. Genetic counselling is a communication process, and we help individuals and people work through information, try and make sense of things so they can start to be involved in their own decisions. And that can be about managing a condition, but also about what they want to do about it. Do they want to be tested for a condition? Do they want to make any different choices based on that diagnosis? We talk about genetic testing, explain the process, and a big part of that is often discussing timescales and making sure people have a reasonable understanding of what is involved and how long it may take, and also the limitations of it. We are not yet in a position where we can do a genetic test that identifies all genetic conditions. So somebody may well have a genetic diagnosis, but we can't identify the cause of that on genetic testing. So we have to make sure people fully understand the role and the limitations of genetic testing, and also that we sometimes get results that we don't know what they mean. These are really, really frustrating for everybody involved, but it is still the situation with genetic testing that sometimes we pick up a result and we can't say whether it's actually causing a problem or it's just normal variation, and we don't know yet which way to view it. We're also involved in discussing options available in a pregnancy, if people want to discuss that. So for some types of EDS, there is testing available in a pregnancy, and it's a really personal decision about whether somebody wants to make choices in relation to that or not. And we are very much led by people, so we're classed as a non-directive service, so we don't tell anybody what to do. We just try and work out what people are wanting and facilitate their choices with that. So what are the benefits of genetic counselling? The aims really is that people get a better understanding of the condition in their family, have the opportunity to ask questions, find out what they want to know, and be able to make decisions on the basis of that better understanding. Knowledge ideally is empowering. Sometimes it brings loads of extra questions, but the aim is that by understanding and knowing about a condition, people can make their own choices. Also, with genetic conditions, often people who have been the first person to get a diagnosis in the family have a sort of a situation then when they are sort of having to share that information with other people, and that's really not an easy thing to do. So we often talk to people about, how do you bring it up with other people? Is there any way that we can help with that? Making sure that people in the family are aware of things that may affect them. There's a sort of a feeling sometimes of having the burden of having to pass on bad news to people, and we really try and make sure people know that that actually it can be a really helpful thing to be able to share that with other people, but certainly is not an easy situation to be in. Having the information, having the knowledge, it allows people to take action to manage the condition. Hopefully, as best as they can in that situation. It often, again, is not easy, particularly when a diagnosis is newly made in a family. There's a lot of things to think about and get your head around. I often think that after a new diagnosis, I sort of expect it to take a good year for people to get their head around what it means for them, how they manage it, how they deal with it, and how they bring it sort of the everyday life back with this extra information in it. So it's there's no quick fixes on anything, but working towards kind of being able to cope with a diagnosis. We try and help people communicating with other health professionals, teachers, social workers. We very much include Annabelle's challenge in our discussion with people with a new diagnosis of vascular EDS, because we know that Annabelle's challenge are incredibly good at doing all of these things. So we're sort of also sort of aim to give people extra resources that can help in communicating and coping with the diagnosis. So, what is the genetics clinic? So there are, somebody in the waiting room, shall I? Oh, they're in, cool. There are regional genetic services in the UK, so 23, I think, but the number may change. So these are regional services, often based in large centres, but they often work in a hub and spoke setup. So they are able to provide local genetics clinics at many sort of local district general hospitals around the UK. So the whole of the UK is sort of covered by the regional genetics service and the local kind of clinics that they offer from those hubs. Each clinical genetic service has the clinical team and the administration team, the clerical team. Doctors, genetic counsellors make up the clinical service, and they're involved in seeing people with all different types of genetic conditions, making diagnoses, offering predictive testing to the family members, discussing pregnancy and options. And those teams also work in relation to other specialists, other hospital services, offering MDTs, specialist clinics, and they link really closely with the lab services to organise and arrange genetic testing. Many people who are referred to the specialist EDS clinic have been seen by a regional genetic service first, and each service covers a part of the UK with a sort of a population of between 1 and 5 million people, and often our referrals do into the UK National Diagnostic Service for EDS do come from regional genetic services, but we also get referrals from many other specialities as well. So lots of regional specialist genetic services, but just two services that offer the EDS National Diagnostic Clinic, one in Sheffield, where I'm based, and one in London. And between us, we just sort of split the UK. So Midlands and down go to London generally, Midlands and up come to Sheffield, and we often get patients referred from Ireland and Wales. But actually, it's patient choice where people go to. If somebody finds it much easier to get to one clinic than the other, they can just let us know. So the two teams, so the London team, this was their recent Reds for Veds picture, and they're based at Northwick Park Hospital in Harrow, and you can see, I don't know if you can see my arrow, but Juliet, Carol and Ravi, I think is down in the corner here, are the three genetic counsellors in the London team. In Sheffield, we're based at the Northern General Hospital. We are actually part of Sheffield Children's Hospital, but we see adults as well as children. Clinical genetics services have traditionally have often been based in children's hospitals because we do see children, but we see all ages. And this is our home. And so we've got our recent, we slightly distanced Reds for Veds picture. When we didn't have to distance so much, we actually got some cakes out, which was much nicer. So, patient pathway, what happens when you or a family member is referred to the EDS service? There's sort of two kind of main routes for referral. So if I talk about them separately. So the first and most common route is when people don't have a diagnosis, but there is a question mark about whether they could have one of the rare types of EDS, and they're referred to us to try and answer that question. So here we've got the example of Tina, who's been seen by dermatology. She's got a history of fragile skin, easy bruising. She's had some complications after a planned surgery, and she talks about a family history of blood vessel ruptures. So the question has come to us, is could Tina have one of the rare types of EDS? The other route that we are getting actually more and more referrals for is when people have a known diagnosis of one of the rare types of EDS. So in this situation, Bill has recently had a vessel dissection, was seen by his local genetic service, and genetic testing was done and confirmed a diagnosis of vascular EDS. Because we have a large amount of experience in vascular EDS now, it is really appropriate for people to be referred to the service, although we're called a diagnostic service, but to be referred to the service when a diagnosis has already been made, so that we can add in the expertise that we have in terms of advice and management of conditions for the rare types of EDS, so vascular EDS, classical EDS, and the even rarer types. So the patient pathway. The first step is that we get a referral. We get a lot of referrals, and we have to triage those referrals and check that they meet our referral criteria. So we only accept the referrals that we think we can actually make a difference with. If we get a referral asking for something that we're not able to offer, we just write back and say that's not what we do with this service. Usually when the referral is accepted, our coordinator, our secretary, Yvonne or Dawn, get in touch with the family. So this is what happens in Sheffield. Get in touch with the family and say we've got this referral, just checking details and make a plan for a phone call with the genetic counsellor. I'll talk a bit more about what happens at that phone call in a bit. The next step after that phone call with the genetic counsellor is a clinical appointment. We generally like to do these as a face-to-face appointment in the clinic here, but we have, like everybody, sort of managed our way through COVID with various telephone and video options where we've needed to. And then following this appointment, we make a plan of what's going to happen next. So we get that referral, first of all, and we start by making sure we've got lots of information. So if the referral mentions any sort of history, we'll make sure we've got that from the place where it happened or the hospital where somebody was seen, get scan reports, get test results if things have already been done. So we get as much information as we can before that phone call. At the phone call with the genetic counsellor, we're going to try and work out where the patient, where you are at, and also sort of make sure we've got as much information as we need to go forward with the appointment. So what happens in that call? We want to first find out, what is happening for you, what has led to this referral, what do you want from this appointment, and this is always different for everybody. So we never know. Coming into one of these phone calls, we never know what exactly is going to come up, because it depends on the person that we're talking to. So we really want to get a good idea of where you're at. We also want to gather information. So we always take a family history. And it's sometimes the case that people don't know information about the family history. That's absolutely fine. That happens all the time. We're really used to that. So we just take the information we can and work with that. We also take medical history and just make sure that we have got all the details we need to gather anything before the appointment. So find out which hospital scans have been done at and such like. We sometimes talk about genetics, inheritance patterns, depending on where we're at. If somebody has a diagnosis already and has questions about that, I find talking about genetics over the phone quite challenging. I've had to improve a little bit over the last year as we've done less things face to face, but it is quite nice to be able to see people draw through patterns of inheritance and explain things fully. We also talk about what their options are. Coming to this appointment doesn't mean that anybody has to do anything. You can come for information, you can come and see what we say. If somebody wants to have testing, if we're able to offer that, it's still that person's decision what somebody wants to do. The majority of testing we do is now done on a blood sample, but we also have sort of offers of skin biopsies in some cases where we think that might be helpful, and occasionally other types of testing. So we always make sure people know, what we could be saying in that clinic appointment. We could be perhaps offering a skin biopsy just so they've got a bit of a advanced information to be able to think about what they want to do. And we check if some people have any questions, and that might be questions that we can't answer at this point in time that we just take away with us and bring back at the clinic appointment. But a big part of what we do is just making sure people have an opportunity to air their questions. So onto the clinic appointment. Length would vary depending on whether a diagnosis is known or not, or whether somebody's being examined in sort of the aim of trying to direct testing and get a diagnosis. But regardless, really, we tend to take about 30 to 60 minutes in our clinical genetics appointments. More often 60. We usually have a lot of information to discuss and talk about. At that appointment, we have the consultant and the genetic counsellor, and we try and make it the genetic counsellor that you spoke to on the phone, as much as possible. We ideally do a clinical examination at this appointment as well, and that tends to involve wearing one of the lovely hospital gowns. So we always do prepare people for that in the phone call before that. And we do an examination whether there's been a diagnosis made already or whether there hasn't, and that's because we always need to make sure we're not missing something else, even if a diagnosis has been made, and also that we're gathering as much information as we can about these rare conditions, because we use that information to be able to talk to people about diagnoses. So it is really helpful for us to do that examination. we have a detailed discussion, and we always do, whether that's about what we can offer in terms of testing or what results have shown, and we talk about genetics and inheritance patterns, and make sure we always give an opportunity for people to ask all of their questions. Sometimes I say to people in advance, if you feel like you've got loads of questions in your head, bring a whole list to the clinic appointment. We never mind that. We never mind, people checking off a list of questions, because it is a good opportunity when you've got both the consultant and the genetic counsellor together to go through those. So following on from that appointment, we always write a letter to summarise the appointment, have a plan of action after it. It may be that we're going on to do some testing. It may be that we're giving recommendations for what should happen next. It may be that we don't think we've got an EDS diagnosis, and actually we think somebody should be seen by a different service. Or if we have got a diagnosis, we may give details of support groups. Sometimes there may be research options, and we can sort of make sure we've got plans for what people want going forward, and how we sort of offer that. So whether that's having a follow-up phone calls, or we always sort of offer the chance for people to get back in touch with us with any questions they have, or whether we're sort of referring people on to one of our joint clinics. So with vascular EDS, we do a joint clinic with the cardiac team, and we always refer people to that if they're happy for that, and that means that we've got a sort of a plan to make sure we keep in touch with that person through that joint clinic. So follow-up and support for people with vascular EDS. So yearly check-ins. So we try and do this, but we always have people to contact us anytime with any questions. Often this might be in the joint clinic, or for people, so we start the joint clinic from the age of 13 in Sheffield. So if people are under that age, it might just be a quick phone call catch up and see where people are at and what they're wanting. As I mentioned, the cardiac clinic, so we call it the Inherited Cardiac Conditions Service, the ICC service, and we do our joint clinic with them. We always give lots of information about vascular EDS and how we think it is best to manage this condition. People can make their own choices. So when we give information, we try to make sure that people know that what we're doing is giving that lifestyle advice and giving that management advice, but we're not telling people what they should and shouldn't do. But we need people to know that the activities that may be more risky for them or less risky for them, to make their own decisions that are right for them. And often people do want that information to know, how to avoid extra risk with a condition like vascular EDS. In terms of management, we talk quite a lot about what to look out for, what the risks are with vascular EDS, and when do you need to go and get checked, when do you need to go to A&E. We have the emergency information card for medical professionals. I don't know if you can see me or just the screen at the moment. I'll hold it up in case you can see me, but I'll show it afterwards if not. And we know it is a really hard condition, having vascular EDS and needing to go for emergency investigations because you have concerns, but going to see somebody in A&E who doesn't know anything about the condition. So very early on in the service, we realised that we needed something that was able to sort of help people in that situation. So we developed the emergency card. We review it really regularly, and we still think it has the information that is needed by A&E doctors in emergency situations. What we cannot do is make people look at it and read it, but by giving it to you, the sort of the aim is that you're able to pass that information on and people will take note. Yeah, we hope it really does make a difference in this condition, but we know there's still a long way to go in kind of getting the emergency management as a smooth process for people, so that the right steps are taken quickly. Often people have questions about who to tell, how to tell people, whether that be family members, employers, other health professionals, school for children. There's various different information leaflets we also provide, but we will kind of talk to people and make sure people feel more able and more prepared to talk to others about this condition. We can provide letters to pass on to relatives so they can be seen by the local genetics team, and if then a diagnosis is made in somebody else, then can get referred through to the specialist service. We also talk, as I've mentioned before, about Annabelle's Challenge and the EDS UK support group, and the roles that they provide, which are fantastic. We always let people know that if they're seeing any medical professionals, they need to let them know about the diagnosis, but they can also pass on our contact details. So if somebody is having any planned surgery or planned investigations, let us know, let the team that you're being seen know about us, and we can discuss in advance any sort of extra sort of things that need to be taken into account when somebody's got a diagnosis of vascular EDS. We're often contacted for advice in emergency services, and we are very happy to be contacted, but we are only here Monday to Friday, 9 till 5, and you know, in my experience, things always seem to happen at the weekend or in the evening, so we can't always be there, and that's the real reason why we've made sure we've got the emergency card with information. But we're always happy, if you're seeing any doctors, to let them know to get in touch with us, and we can always sort of discuss information with them as well. I think we've mentioned this already, but you know, options for pregnancy very different depending whether you're male or female with this diagnosis, but there's a lot of information that we can talk about and make sure people are making the right decisions for them in this situation. And any general questions, so you know, what we would always say is that if anybody has any questions, get in touch with us anytime. It doesn't matter whether you're not sure if it's a silly question or not. You know, we get all sorts of questions, and even the silliest ones, sometimes I have to go and check with other people because I don't always know the answers to most of the questions that come up. But we aim to try and get the right information to people, and that may be that we don't have any answers, but we're absolutely always happy to be asked questions. So I think, oh, there we go. That's just a reminder that we are a small team. We do what we can, but absolutely do make sure people know about the diagnosis if you're seeing any other specialties, and wave the emergency card around as much as you can, and make sure people look at it. We think it's really important and helpful. So that is the end of my talk about the genetics clinic. I hope that's covered some of your questions. If it hasn't, let me know. So I might stop sharing now and see if anybody has questions after that. Okay. So does anybody want to ask anything to follow on from that? Yeah, thank you.
It's more about the medical alert document, which, as I say, I hand around like confetti when we go to A&E, and everybody reads it, and everybody's always very pleased to read it, which is brilliant. You know, oh, I haven't, you know, yes, please, and they. But when we went in August with George had 2 dissected vertebral arteries, they still wanted to do an angiogram, having read that document. And I really had to stand up and say, no, you can't do that and it wasn't until they'd spoken to his cardiologist, to Catherine von Klemperer, that they said, oh, okay, we won't do it. Yeah. So I don't know if it can be made more obvious on that document that it's invasive procedures, but they still follow the sort of they said, well, but this is what we do when somebody comes in with a dissection.
Yeah, absolutely. I mean, so I've got the card if anybody's not seen it. We've tried to make it as clear as we can on this card. I'm sure you know it already, but the first in bold on the first page is patients' concerns should be taken seriously and any reports of pain need full and immediate investigation, followed by how to do those investigations.
Yeah.
We try to make it really clear, but what we've always said from the very start of the service is you have to be absolutely advocating for yourself with this diagnosis, and that is really, really, really hard. And if you ever need backup, get in touch with us. But yes, you do have to keep telling people that, you know, they need to look at what it says, they need to do what it says, and this is a condition where people shouldn't have the routine plan of treatment or investigation. Yeah,
I think particularly angiograms, it's almost worth saying it, because that is such a, you know, that's such a standard procedure for anybody who's got any form of vascular rupture, and yet, you know, it's an absolute no-no unless it's they're about, you know, you're going to die anyway sort of thing. It's, you know,
yeah,
just and shred everything in its path.
Yeah, well, and the main thing is you can do those investigations in different ways, but you need to be aware of that, which you should be once you've read this, and be prepared to do things differently. So CT, MRI, absolutely the right way forward.
Yeah. Okay. Thanks.
Yeah, I've got a question for you. More and more, like when I'm on Instagram and Facebook, you start seeing all these adverts for the genetic testing, you know, the private ones. I just think that's going to expand, because I think, you know, people can see there's a bit of money in it if they set up a company and stuff like that. My question is, because on a lot of the Facebook groups around the world, particularly in America, you've always got people asking, are those tests worth it, you know, that sort of thing, because a lot of money for them, of course. And my question is really, if, like, as they become more advanced, are they useful? As in, like, if somebody was to ask me, oh, I've had this done, should I see my doctor or whatever, will it be taken seriously? Are they worth it?
Really good question. So the Association of Genetic Counsellors and the British Society of Medical Genetics at the moment do have some really good statements on direct-to-consumer testing. I haven't got any of them right to hand to read them out to you, but we as a profession have concerns about them, because whilst you can do a genetic test, it is really about the interpretation of those results, and that is not what is often being offered with these tests. And the private ones that you can access with a fair amount of money don't often come with the same level of interpretation. Well, absolutely don't come with the same level of interpretation as you would get from an NHS laboratory. And what we know with genetic results is it's all about interpretation.
Right.
So if you're not we all have variants. We all have hundreds of thousands of variants in our genome, but they don't all cause us problems. It's only the very small number of these that are actually having an impact. So you can do a genetic test, you can find lots of information about all these variants that you have, but actually it's not going to answer the question of whether you have a genetic condition or not. The pathway for getting a diagnosis really has to be about, you know, what is somebody's problems, what is the clinical picture, and then using that clinical picture to direct what testing is done, so that when you find something on testing, you're better able to interpret it. Some of the sort of big kind of direct-to-consumer companies are offering some known genetic tests, so that, for example, with using a completely different condition with breast cancer, there are a few changes in two of the breast cancer genes that are a bit more common, and sometimes those are put on, and people are getting that information, but they're not getting the whole gene looked at, so it's not able to actually tell people whether or not they're at increased risk of breast cancer or not. So yeah, I have real reservations about paying privately for these tests. as I think they do cost a lot of money, and I don't think the value that they give people is very helpful. I think, personal view here, but I think they create a huge amount of anxiety for people with information that is not ready to be useful. It's not interpreted properly, and it doesn't give people answers. It just raises loads of questions, and depending on the reason that somebody chose to get that test done privately, in the UK and the NHS, we may or may not be able to answer all of those questions, because unless there was a clinical concern in the first place, we wouldn't pursue that sort of
Right.
path for trying to interpret things, really.
I think many of them are getting them done. I think people are getting them done to prove to the health community that they do have something, because they're not being believed. I think I can sort of understand that, because I think in generally women tend to be disbelieved more than men if they have. And I know myself that I had symptoms, but they were just very vague. Nobody would have picked it up. I never picked it up. I just thought I was just a bit odd. But of course, this was also back during the 70s and 80s. We didn't know anything. But yeah, I can't see it going away. I think it's just going to get bigger and bigger, and it's not regulated. And so I'm just sort of fascinated, really, to see where it will take us.
Yeah.
Particularly as we are NHS is being outsourced quite quickly to private companies. So yeah, I don't know. But anyway, thank you very much for that.
Yeah, I mean, do have a look at there's sort of mission statements on the British Society of Medical Genetics, and I think probably it's also on the Association of Genetic Counsellors. But yeah, when the question is sort of trying to show that you've got something, these tests will show you've got loads of things.
Oh yeah, you'll be dead. The tests show that you're actually dead.
Yeah, you'll come back with many things.
Yeah, it's true.
And presumably there's no counselling comes with these tests either. I mean, which is really dangerous.
Correct.
I would have thought.
Yeah.
I mean, if they do come back with something, bad.
Yeah. Occasionally there may be some, and there are some routes to access private genetic testing in the UK that do come with counselling and are looking at the right conditions and do get the right results, but the direct consumer ones without genetic input, absolutely, that I have a lot of worries about them.
So that's very dangerous.
Any other questions?
I was just going to ask about, I know you mentioned the when you get referrals in and the kind of criteria that you need people to meet. We find it sometimes difficult to explain to people when they've had a referral put through and obviously the referral has been declined, and trying to explain that that's because these guys know exactly what they're looking at and know it very well, and if they don't think it's a concern, but how to kind of manage that they are still concerned that there could be a problem. Are they able to, and it's kind of managing, so we have a lot of people that say, well, I bruise easily, and we kind of say, there's bruising easily, and then there's vascular bruising, very different things. So just kind of how to manage getting patients to understand that genetics are not turning down the referral because they don't think anything's wrong. They're turning down the referral because it's not vascular, or it's not kypho, or it's not one of those types.
So again, really good question. So we really do not want to miss a diagnosis of vascular EDS or any of the other rare types of EDS. So we rely on referral doctors to give us information, and sometimes when we don't feel like we've got enough, we might write back and say, tell us more, why do you think this person needs to be seen? But we are looking for kind of clues from that referral letter to sort of suggest to us that this person would actually really benefit from genetic testing. So what we know, or what we were set up for, is to diagnose the rare types of EDS. And we know hypermobility spectrum disorder and hypermobile EDS make up a far larger group of patients at the moment. And we were not set up to see or diagnose or that group of patients. I know that causes all sorts of frustrations for people, because who was, you know, there's so many challenges, aren't there? But our role is really to look for any clues that suggest a rare type of EDS. We see and we test a lot of people where we find no sign of a rare type of EDS. So we think from that we are still making sure we're kind of covering our bases and making sure we're offering testing to the people that we think need it. We're picking up the people hopefully with that diagnosis, but we're also, where there's more of a question of it, for some people we're able to rule it out. If somebody has concerns, just keep talking to your doctors about your concerns, and referrals that come to us that any clue of any of the rare types of EDS. And it's hard to give a list of the things that we look for, because it's various different clues that we pick up in either family history or personal history that come on the referral letter. But perhaps we rely on the referring doctor to make sure we've got all the information in that point. But we do decline a lot of referrals, but we really are keen not to miss diagnosis of the rare types of EDS. So we think we set our sort of acceptance criteria wide enough to avoid missing things.
Yeah, absolutely. I think it's just getting members and things like that to understand that it's not, and especially if a referral letter goes out and it's describing head, ticking every box for head, and there's nothing else that would signify. We're kind of saying to people that there's no reason to need to go to genetics, because it's not going to show anything. So kind of moving away from this, I think, because people see it's a genetic condition, they're like, well, that's a go. We're like, it doesn't quite work like that. And there are sometimes people that have been diagnosed with heads and they call up and they start describing symptoms, and we go, that sounds vascular-esque, you need to get a referral.
Yeah,
but they're quite rare to get those kind of calls. But it's good to know, just kind of, it enables us to have more ability to kind of say, that referral process is secure. You need to trust it. And if you are still really concerned, go back to your GP and say, actually, I've got this and this, can you put that in the referral letter and see if that maybe is more.
Yeah, and we get referrals that we say, no, this doesn't meet our criteria, and they come back and we check again and we say no still. But yeah, it's fine to do that. But yeah, do trust that we are really keen not to miss it.
We trust. Just trying to get them to as well.
Yeah, we know how important it is to make diagnoses. So yeah, that's our goal.